Welcome to episode 3 of the PancChat podcast. This episode focuses on the risk factors for pancreatic cancer. I'm Julie Fleshman, President and CEO of the Pancreatic Cancer Action Network. Our host, Alisyn Camerota, is joined by Dr. Anirban Maitra and Dr. Michael Goggins to discuss this very important topic. Thank you for joining us as we explore what puts people at higher risk for pancreatic cancer and, most importantly, how people at higher risk can be monitored.
Hello, everyone. I'm Alisyn Camerota. Thanks for joining me on PancChat. We want to thank our sponsor, Revolution Medicines, for their support. So today's guests are Dr. Anirban Maitra. He's an internationally recognized pathologist in gastrointestinal cancer research and translational oncology. He'll be joining NYU Langone this September from MD Anderson, and he will be the new director of the GI Cancer Center and associate director of the translational research at Perlmutter Cancer Center. We also have Dr. Michael Goggins. He is a professor of pathology, medicine, and oncology at Johns Hopkins University. He practices gastroenterology at Johns Hopkins Hospital, and he is the director of the Pancreatic Cancer Early Detection Research Lab at Johns Hopkins. Both Dr. Maitra and Dr. Goggins have been the recipients of research grants from PanCAN. Gentlemen, it sounds like we have the perfect guests for today's conversation.
Thank you for having us, Alisyn. I really appreciate it.
Welcome.
Nice
really
to be
looking forward to this. Okay, so let's begin with, as I understand it, the 3 main categories of risk factors for pancreatic cancer. So those are lifestyle, disease-related, and inherited. So Dr. Maitra, let me start with you. Can you help us understand more about each of those 3 categories?
Sure. So I think we've learned a lot in terms of risk factors for this disease, which unfortunately still sort of strikes sort of out of the blue in most individuals, unfortunately. We do know that in most patients, there's not one attributable risk factor that you can point to and say, this is what caused the cancer, except for a subset. A minor subset, you can say this is most likely the cause, but in most individuals who get diagnosed with pancreas cancer, you can't say, well, for sure, we know this is what caused the disease. Unlike, for example, with lung cancer and smoking, or cervical cancer and the human papilloma or HPV virus, you can say, we know this is what caused the cancer. It's hard to do that. But with that said, there are some risk factors that we do know contribute to pancreatic cancer development, one of which, in terms of lifestyle, is obesity. We know this is one of the cancers that is associated with a high body mass index. And certainly as the rate of obesity has gone up, so too has the incidence of pancreatic cancer. In terms of disease-related, I would say inflammatory conditions of the pancreas, most importantly, pancreatitis is a very important risk factor. Alcohol and smoking, which I guess are also lifestyle-related, but do in turn cause inflammatory conditions in the pancreas, would kind of be at that interface of lifestyle and disease that contribute to pancreas cancer. So obesity, pancreatitis, smoking, alcohol are some of the big ones. Mike, maybe you can focus on the inherited and anything else I may have missed here.
Yeah, go ahead, Dr. Goggins.
Yes. So, among inherited factors, we can discuss that inheritance is also not determinative. So if you have a family history of the disease, you're at increased risk. And we can talk more about it, but the extent of your family history matters and how close the relatives are. Most people who get pancreatic cancer don't have an immediate blood relative with the disease. But having said that, it's certainly an important risk factor. And for pancreatic cancer, like for a variety of diseases, some of the cancer genes that people can inherit, the BRCA genes, certain other genes, also contribute to pancreatic cancer risk. So those are, very important factors because, we can do gene tests in the clinic now routinely and really help us understand. We can take a detailed family history, and these are risk factors that don't change. So they're very important to understand it, and we try to use these in the clinic to decide who needs, kind of early detection. In terms of other diseases, it's worth mentioning you could consider some of the incidental findings on the pancreas that we'll see that people who have imaging abnormalities in their pancreas that reflect precancerous changes. Pancreatic cysts, for example, are quite common as you get older, and although they don't convey necessarily any great risk, that's a challenge with many of these risk factors. Some of them are only mildly associated with risk, as opposed to being very powerfully at risk. But having imaging abnormalities in the pancreas that can create concern, like pancreatic cysts, that would be another disease. And then you could also take the obesity question, and there's diseases related to that, and there's overlap. So people who have obesity may or may not have a metabolic syndrome. So they'll hear that doctors will sometimes tell their patients they have a metabolic syndrome. Conditions that are associated with that, like having a fatty liver, having conditions like sleep apnea. These are where your body's metabolism is off, and the diabetes is often a disease that is associated with pancreatic cancer risk to a certain extent.
So, Dr. Maitra, of those three, is there one that you think is more determinative of lifestyle, of disease-related, or inherited? Is there one that you pay more attention to?
Well, inherited is the smallest slice, so to speak, but it's the one that you cannot change, but where you do have some mitigating factors you can pursue, and one where physicians like Dr. Goggins, who are gastroenterologists, can actually put individuals on surveillance. So if somebody has a particular DNA alteration, or what we call a mutation in their genes, that causes them to be at higher lifetime risk for pancreas cancer, then you can definitely tell them, one, don't smoke, try to reduce your alcohol intake. So don't do the other lifestyle things that may increase that risk. But then if this is a particular gene, and not all the genes have the same risk of pancreas cancer, some are only modest and others are quite high. If you're on the higher side, maybe talk to Dr. Goggins and see if you can get on his surveillance program, so that, heaven forbid, in case cancer develops, we can catch it really early, or maybe even at the time it's just getting to cancer. Because what Dr. Goggins and others have shown is that these individuals, when they are on these surveillance programs and the cancer is diagnosed early, they actually do really well, much, much better than your, run-of-the-mill community diagnosis that happens outside of these surveillance programs. So I would say the smallest slice is the inherited slice, but it's the one where we've really made a lot of progress. The other one, as Mike mentioned, in terms of the disease, the cystic lesions. This is, and I should have mentioned it, but this is something I'm glad Mike brought it up. It's becoming an epidemic in a way that it's almost a man-made epidemic, because so many Americans are now getting abdominal scans for unrelated reasons. I mean, you have some right abdominal pain for potential gallstone, or somebody gets into a car accident or whatever. You get scans. There are tens of millions of scans done every year, and some of these will pick up a silent cyst. These cysts are little fluid-filled bags in the pancreas that have a small, very small risk, but a real risk of getting pancreas cancer. And so those are, again, we have tools that we can use to follow these individuals. And so I would pay some attention to those individuals as well, because again, we have the tools to mitigate the risk of getting to cancer in those individuals. The lifestyle changes, I mean, again, alcohol, smoking, obesity, that's really advice that you can give. And you hope that individuals will take that advice in all seriousness and pursue it. I think, for example, with the obesity question, there is now these GLP agonists that everybody is really excited about. So I guess you also have an active prescription that you can give individuals to lose weight and potentially mitigate the risk of pancreas cancer. But again, these lifestyle risks, the contribution of any individual one to pancreas cancer is much less. It's always a cumulative sort of contribution over multiple things. You have obesity, but you also smoke, and you might take more alcohol than you should, and so it all kind of adds up. So any one given thing is hard to necessarily reduce the lifetime risk of. But with the hereditary conditions and the cystic lesions, you can actually follow these patients and do something to catch the cancer early.
Dr. Goggins, how do people get on your surveillance list, or how do people, what's the mutation they have to have, not just your list, but what's the mutation they have to be surveilled?
Yeah, so the way we've thought about this, and our practice has evolved. The pancreatic cancer early detection community who practices this. We started out first do no harm. Select the people we think are at the highest risk. Over time, we've felt more confident that what we do can make a difference. So we enroll people with certain family history criteria, certain gene mutation criteria, and a certain age criteria into the hereditary programs. And then there are the parallel programs, and they can overlap, of course, as well, where people, they come and they get a CT scan for, something, and, as we were discussing, an abnormality like a significant cyst is seen, and then we decide that, well, maybe we should keep an eye on that those are often little baby precancers that often do lead nowhere. So those are the two main surveillance programs. But you want a family history that meets certain criteria. That's how many family members, close blood relatives with pancreatic cancer. One close blood relative with pancreatic cancer, increases your lifetime risk modestly. Most people, we think the lifetime risk is under 2% for pancreatic cancer. If you have a family member, even one close blood relative, that may double the risk or so. If it's a young onset pancreatic cancer, maybe even a little more so. So we think about people even when they have one first degree relative, although most people we think maybe they're not eligible. Usually we start surveillance at middle age. If you have two first degree relatives, or you have a first degree relative and a second degree relative. So that's where we're thinking about how does the family history add up? What is your relationship to other members in your family with pancreatic cancer? And then some people will get a gene test done. Often, a relative in their family has informed them that, they carry a BRCA gene or some similar gene, and they get tested. And then, that those risks are they're not determinative by any means, but those gene mutations, they carry a higher risk. And so those are the kind of people we enroll. We hope one day we're knowing that, well, you smoked, or you have obesity, or you have metabolic syndrome, and you don't have the family history, but your overall risk is that we're still trying to understand risk and quantify it better so we can tailor screening for who needs it. At the moment, we kind of do okay, but we really don't have. It's very hard to predict risk, as you can imagine, for future cancers. But what we rely on mainly is the family history and the gene mutations.
Yeah. In my personal history, in the case of my husband who died of pancreatic cancer, there turned out to be a connection between kind of a pre-diabetes track and a spiking of blood sugar. And that turned out to be a huge risk factor, but we didn't know that at the time.
Yes.
We didn't know that there was a connection to pancreatic cancer, and his primary care physician didn't flag that there was a pancreatic cancer connection. So Dr. Maitra, your thoughts on that?
I mean, it frustrates me no end, to be honest with you, Alisyn. I mean, I can't tell you how many talks I've given where someone comes up to me at the end of the talk and says exactly the story that you just said, And so to me, this connection between new onset or worsening diabetes, particularly if it is associated with weight loss, is an incredibly important connection that is missed by our primary care physicians. And we worked hard, PanCAN and Let's Win and others have worked hard to really spread this message out in both the lay community as well as to the physician community. It's shocking to me how many physicians don't know this link, that new onset diabetes in the elderly for the first time, especially if it's accompanied by weight loss, or the weight loss doesn't lead to improvement in the sugar levels, the diabetes levels, are potentially, not always, but potentially a warning signal that there might be an occult or silent pancreas cancer. And so we have looked into this. Actually, we have done studies, and we have shown that in individuals older than 50 plus 55 years or so, there is a 7 to 8 fold higher risk of carrying a pancreas cancer if you present with new onset diabetes for the first time at that age group. Again, because the absolute risk for pancreas cancer, thank heavens, is still small. Even a 7 to 8 fold risk is not very large in numbers, but it is still much larger. And it's certainly something that would warrant doing additional blood test, or if you were really concerned, some sort of an imaging study. But it keeps getting missed. And I want to also emphasize one thing. We're talking here about, again, exactly the unfortunate scenario that happened in your personal story, which is it's new onset diabetes. There is a risk factor that long-standing diabetes also contributes to pancreas cancer, diabetes longer than 15-20 years, but that's a very small risk. Like we're talking just a little bit more than baseline. Here we're talking about something that is caused by the cancer. So when we use the word risk in the context of new onset diabetes, we're not saying that diabetes is causing the cancer here. This is different from that long-standing diabetes. What we are saying is that cancer is causing the diabetes. The diabetes is a sign, just like jaundice or weight loss, except it happens much earlier, and therefore you have a window of opportunity to catch this cancer early if only action is taken. And so information is key. And one thing that I'm hoping podcasts like this will do is get more of that message out there. If you have somebody in their 50s show up for the first time and their diabetes is not responding to the usual advice, lose weight, eat better, take this medication, at least think, could this be something else? And you'll be shocked how many times that doesn't happen.
Yeah, I totally agree with you, Dr. Maitra, that is the message that we need to get out. I mean, I think about the different trajectory my family history would be on right now if a primary care physician had known of that connection. And so Dr. Goggins, it is, I mean, this was, 5 years ago. God willing, there's been more awareness, but it does seem like you're going to need buy-in from all of the primary care physicians and others to know about this in order to flag it and get screened and tested.
Yeah, and the study that Anirban has been involved with and PanCAN, it's a very important study to help highlight and to see if intervention can help. Because the challenge is, of course, there's so much diabetes in the community, and so there's a primary care physician. It may be only 1 in every 100 or 200 people who has new onset diabetes. And as Anirban is pointing out, when there's something else going on besides new onset diabetes, in other words, is there some weight loss? What we really need are simple tests that help the primary care doc. Another blood test that says, all right, well, let everyone with new onset diabetes, have a test that says, well, this one's a little different. This is not your usual new onset diabetes. This is a concerning new onset diabetes. And then we can, get you seeing a scan. But you're right. At the moment, we that message is not out there with the primary care physician.
Yeah, and we are going to talk about those kinds of tests in one of our next episodes. About that, Dr. Goggins, what about the children of somebody? Obviously, I ask for my own personal interest, but I know a lot of other parents who think this. If you're the child of somebody who had pancreatic cancer, how concerned should you be, and should you be screened?
Yeah, so you have to take it into context that, again, unlike breast cancer, for example, lung cancer, pancreatic cancer is thankfully not a common cancer compared to those, although its incidence is going up. If we estimate that the lifetime risk of pancreatic cancer is less than 2% in your life, even having a family member with pancreatic cancer, hopefully, or an immediate blood relative, a parent, your lifetime risk is probably close to 5%. That if you take all comers. Now, if someone has a gene test done and that their risk can change, if they have more than one relative in the family who's a blood relative, that risk can increase. So we're certainly, wanting to be able to intervene and offer something for people who have an immediate family member. Pancreatic cancer, although its incidence has risen a little bit in younger people, is really a disease of people who are, middle-aged and older. It's not common at all in people under 50. Our surveillance programs are mainly for people age 50 and older, and with the risk going up, even people in their 80s, so can be getting pancreatic cancer. So that lifetime risk is over a long period of time. So if you're a young person and you've been devastated by having a parent dying of pancreatic cancer, you're still a young person. For certain cancers, if that happened, a young onset breast cancer, for example, you got to get screened early at a young age. For pancreas cancer, the value of doing it, that is really not there until you're really middle age in general. Maybe there's a young onset cancer. Maybe you have a gene test that suggests in a rare instance we should start surveillance early. So yes, there is a risk there, but it has to be put into proportion. This is spread out over a lifetime. Vast majority of people who have a family history of pancreatic cancer aren't going to get the disease.
Yeah, yeah, and coming back to that earlier question you asked me, Alisyn, if I can jump in about which of the categories you can place some more emphasis on, and this is why I mentioned hereditary. It's a small slice, but it's the one that you can really do something about, because if the person who was what we call the proband, the person who's first diagnosed with the disease in the family, happens to have a mutation that you can test for now for $250, you can test for a large number of these mutations, and you don't even have to give blood for it. You can spit into a tube, send it to a company, they'll send you back the results. It's this is 2025. We can do this very easily now. And if the unaffected family member, like a child, now has that, then you should definitely speak to a genetic counselor or a gastroenterologist like Dr. Goggins and see, do you merit getting on a surveillance program? So it's a small slice, but that slice is something where information truly gives you the power to do something about it.
And so last, doctors, and you've touched on this, but maybe you can just wrap it up in a neat bow for all of us. What can people do now to reduce their risk, especially if they have one of the risk factors that we've talked about?
Well, I'll say, and then Mike, you should put the final bow. But one, don't smoke, please. That's a general advice if you can avoid it. I mean, it's not just pancreas. Many cancers in the body are impacted by smoking. If you do have a family history, for sure, do not smoke. I've personally given up alcohol as of a year and a half ago for health reasons, and I think you don't have to give it up, but in moderation. Again, it is one of the obesity-associated cancers, so it's good to have reasonable weight and exercise and all those good things. And then again, I can't emphasize this enough. Information is power. If you have a family history or a first-degree relative, it's okay to know it. Do you carry a gene? And you can do that now fairly easily. And then if that is the case, talk to someone like Dr. Goggins.
Yes, and I would add that all of the lifestyle, we need to lead a heart healthy, a mentally healthy life across, to prevent many cancers and diseases. But we still screen people for breast cancer. We still do colon cancer screening. We still do a variety of screening, even though we of course recommend living a healthy lifestyle. So the main thing is identifying whether or not you would fit into you would be eligible for pancreatic surveillance. Currently, that's getting scans and things. There's a lot of work going on. Could we one day have blood tests? Could we one day make the screening more available to the rather than the narrower subset of people where the risk is on the higher side? So see if you're eligible for screening. Figure out if what your family history is. It's not easy to figure out what your family history is sometimes. A lot of times it's uninformative. If you have an immediate family member who's at pancreatic cancer, maybe they or you could get gene tested to so you better understand what your risk is, and see somebody so you understand these things with your own doctor, your own gastroenterologist, or genetic counselor, someone who can give you good information.
Well, our doctors have set us up perfectly for our next episode, which is about those very things of screening and testing and their limitations. So, gentlemen, thank you both so much for sharing your expertise with us. Really great to talk to you. And we will be talking to you again about the next phase of all of this. Thank you.
Thank you.
Thank you.
Hi, everyone. I'm Cindy Gavin, CEO and co-founder of Let's Win Pancreatic Cancer. I want to thank Alisyn Camerota for being our host on this episode and Drs. Maitra and Goggins for participating in this important initiative. We hope you will visit PanCAN and Let's Win to learn more from our resources. PanCAN can be found at www.pancan.org. And Let's Win is at www.letswinpc.org. We hope you will tune in to our next episode where we will continue the conversation to look at the current state of screening for pancreatic cancer.